Hi everyone, and welcome to our module on diabetes treatment. In other videos I talk about the differences between type 1 and type 2 diabetes, but in terms of treatment you should be aware that type 1 diabetes is treated mainly with insulin, and that's because these patients lack the ability to produce insulin from the pancreas. In contrast, for type 2 diabetes, the problem is insulin resistance, so there are oral or subcutaneous drugs that can be used to improve the blood glucose level without using insulin. Insulin is also used in type 2 diabetes, but it's usually reserved for patients with advanced disease. When patients have new onset type 2 diabetes, the most common initial therapy is the oral drug metformin, and we'll talk about metformin in this video and also other oral and subcutaneous drugs used for the treatment of diabetes. I talk about insulin in another video. When you treat patients with diabetes, the treatment goals are based on the hemoglobin A1C value. In patients who have type 1 diabetes, the goal hemoglobin A1C value is usually less than 7%. For type 2 diabetes, the goal is also usually less than 7% for the average adult patient. However, higher goals like less than 8% are sometimes used in older patients, and I talk more about why this is the case in other videos. The lower the value of the hemoglobin A1C, the lower the average blood glucose level, and achieving the target hemoglobin A1C has been associated in a number of large clinical trials with reduced risk of diabetes complications. In type 1 diabetes, studies have shown that the risk of most diabetic complications is reduced by achieving intensive glycemic control and an A1C value at target below 7%. In type 2, the studies are a little bit different. They've shown that if you're able to achieve glycemic control and a target A1C, you reduce the risk of microvascular complications, especially retinopathy and nephropathy. The studies in type 2 diabetes, however, have not shown a reduced risk of macrovascular complications like myocardial infarction and stroke when you achieve target A1C values. Shown on this slide are the major classes of anti-diabetic agents that are used to treat type 2 diabetes. Most of these are oral drugs, although some are subcutaneous. And so we'll go through each of these classes of drugs in the next few slides. When you're treating type 2 diabetes, usually you begin with one drug, and then more are sometimes necessary to achieve the target A1C value. And once patients are requiring high dosages of 2 or 3 medications, that's often when a switch is made to insulin therapy. We'll start by talking about metformin, which is a biguanide medication. Biguanides are organic compounds that have lots of nitrogens like metformin does. There are other biguanides, but metformin is the only one on the market that's used today. Metformin is an oral medication and its exact mechanism of action is unknown, but it has multiple metabolic effects that are beneficial in patients with diabetes. First of all, it decreases hepatic glucose production by inhibiting gluconeogenesis, so this will lower the blood sugar level. It also increases the effects of insulin. It makes cells more sensitive to insulin, and this is a very beneficial effect in type 2 diabetes because the problem in type 2 diabetes is insulin resistance, so metformin counteracts that problem to some degree. As I mentioned earlier, metformin is usually the first-line therapy in type 2 diabetes. The exception to this is if at time of diagnosis of type 2 diabetes, the hemoglobin A1C is very high. For example, if it's greater than 9.5%, which is a very high A1C. In these cases, metformin is usually not going to be able to bring that value down, and the patient is started on insulin therapy at the time of diagnosis. But when the A1C at diagnosis of type 2 diabetes is only modestly elevated, that's when metformin is often the first drug used. And there are a couple of reasons why it's first line. First of all, it's associated with weight loss, which can improve diabetes. Secondly, it rarely causes hypoglycemia, and we'll talk about this later, but many other drugs used in treatment of type 2 diabetes can cause hypoglycemia. It also does not depend on beta cells in the pancreas. It does not boost insulin production like some other drugs do. And so because of this, it can be used in advanced diabetes even when patients have very little beta cell function left. And then its most common adverse effect is GI upset. It can cause nausea or abdominal pain. It can also sometimes cause a metallic taste in the mouth. It's super high yield for your boards to know that lactic acidosis is a rare but life-threatening adverse effect of metformin. The exact mechanism by which lactic acidosis occurs is unclear and controversial, but it has been shown that metformin can increase the conversion of glucose to lactate. This is a good thing for lowering glucose levels, but if it happens to too great a degree, it can lead to lactic acidosis. And as I said, this can be life-threatening, and it's one of the ways that patients can very rarely die from metformin therapy. The thing to know about lactic acidosis and metformin therapy is that it almost always occurs when patients with diabetes taking metformin have some other illness. For example, patients with diabetes who develop renal insufficiency who take metformin are at increased risk for lactic acidosis. There's also a higher risk in patients with chronic liver disease or heavy alcohol use, acute heart failure, hypoxia, or serious acute illness. So because these things all raise the risk of lactic acidosis, metformin isn't used in certain special situations. One is when patients have a low GFR. Metformin is avoided because it could cause lactic acidosis. In addition, when patients come in the hospital, metformin is usually held, meaning the patient does not take the drug while they are acutely ill. And then metformin is also held during tests that involve intravenous contrast. These tests can sometimes cause transient acute renal insufficiency, and therefore metformin is not given until the test is over and the patient's renal function is normal. Okay, our next group of anti-diabetic agents are the sulfonylureas. These drugs get their name because they have a urea molecule attached to a sulfa group, hence the name sulfonylurea. And the way all of these drugs work is they increase insulin release from the pancreas. They bind to a sulfonylurea receptor in the pancreas. This closes potassium channels in beta cells, and as a result, the beta cells are more sensitive to glucose and amino acids, so they release more insulin over time. Therefore, these drugs are called insulin secretagogues. And sulfonylureas are often used when metformin is contraindicated, for example, in patients who have renal failure, or when patients have side effects from metformin that are intolerable, like GI upset. And you can also add sulfonylureas to metformin as a second agent if patients aren't able to achieve their target A1C on metformin alone. All of the sulfonylureas are oral medications, and they're broken up into generations, and each generation of drugs is more potent than the one that came before it. So because each generation is more potent, you can use a lower dosage, and therefore there tends to be less side effects. So the first generation drugs, which are rarely used in modern practice, are drugs like tolbutamide, chlorpropamide, and talazimide. The second generation drugs are still used sometimes. These include glyburide and glipizide. And then there's one third generation sulfonylurea, and that's glimepiride. In terms of adverse effects, hypoglycemia is the most common adverse effect. Because these drugs boost insulin release from the pancreas, that increased release of insulin can lead to hypoglycemia. This can cause the patient to develop sweating and palpitations. In rare cases, it can lead to seizures or loss of consciousness. And when these symptoms occur, patients need to consume some glucose like juice or a graham cracker, and that will make them feel better. And this often occurs when patients exercise or skip meals. These are times when the blood glucose level naturally gets low, and it can get too low when the patient is taking a sulfonylurea. Sulfonylureas can also cause weight gain, and that's because they cause more insulin release, and insulin causes weight gain by promoting fatty tissue deposition. So weight gain is a common problem when patients take sulfonylureas. And then chlorpropamide, which is a first generation drug that's not used much anymore, has some special adverse effects, which you'll still read about in textbooks. So when patients take chlorpropamide, they can develop facial flushing when they consume alcohol. That's because chlorpropamide inhibits acetaldehyde dehydrogenase, which is an enzyme that metabolizes ethanol. This is called a disulfiram effect because this is the same effect that you get from the drug disulfiram, which is sometimes used to treat alcohol use disorder. And then chlorpropamide can also cause hyponatremia, and that's because it increases ADH activity. Our next group of anti-diabetic agents are the meglitinides. There are two important drugs in this group, repaglinide and nataglinide. Both of these are oral medications, and they have a similar mechanism but a different chemical structure from sulfonylureas. Just like sulfonylureas, they close potassium channels and they increase insulin secretion. But if you look at the bottom of the screen, this is the structure of repaglinide, and it does not have a sulfa group, so that makes these drugs useful in patients who have a sulfa allergy. The meglitinides are short-acting, so they're given prior to meals, and their major side effect is hypoglycemia, and that's because just like sulfonylureas, they boost insulin secretion from the pancreas. As I said, they have no sulfa group, so they can be used in patients who have a sulfa allergy. So sometimes these drugs are added to metformin in patients who have a sulfa allergy and can't take a sulfonylurea. They can rarely be used as monotherapy in patients who have a contraindication to both metformin and sulfonylureas. Our next class of anti-diabetic drugs are the thiazolidinediones, and these drugs are often called the glitazones because they have names that end in glitazone, like pioglitazone and rosiglitazone. These are oral medications and they work by decreasing insulin resistance. They do not boost insulin release like sulfonylureas and meglitinides. Their mechanism of action is complex, but what you want to know about these drugs is that they act on receptors called PPAR gamma receptors. These are found in lots of places in the body, but there are very high levels in adipose tissue. You can also find them in muscle and liver and other tissues, and they modulate the expression of genes, and through this modulation of gene expression, they lead to decreased insulin resistance. The most important thing to know about these drugs is their side effect profile, because this often comes up in board questions. So first of all, they can cause weight gain, and that's because, as I said on the last slide, those PPAR gamma receptors are found in adipose tissue, so they can cause proliferation of adipocytes. They can also cause fluid retention, and both of these things can lead to weight gain. There is a risk of hepatotoxicity. An older drug, troglitazone, was removed from the market due to cases of liver failure in patients taking this drug. And then edema is the major adverse effect of the glitazone that you want to remember. This occurs in about 5% of patients. It has to do with PPAR gamma effects in the nephron that lead to increased sodium retention. So there is a risk that patients can develop pulmonary edema. And so for this reason, the glitazones are not used in patients with advanced heart failure. And it's super high yield to remember this. If you use these drugs in patients with advanced heart failure, you can worsen their fluid retention and cause pulmonary edema. And then one sort of special thing is that pioglitazone is not used in patients with active bladder cancer. That's because in some studies there was a small signal of an increased risk of bladder cancer in patients taking pioglitazone. Our next group of anti-diabetic agents are the GLP-1 analogs. Drugs in this group include exenatide, liraglutide, and dulaglutide. And all of these drugs work by mimicking the effects of GLP-1, which is glucagon-like peptide 1. This is a protein that is produced by cells called L cells in the small intestine, and it's secreted after meals. And one of the things it does is stimulate insulin release. It also blunts glucagon release and slows gastric emptying. But because GLP-1 stimulates insulin release, these drugs can function as GLP-1 analogs. They mimic the effect of GLP-1 and they boost insulin release from the pancreas, and that's why these drugs work in patients with diabetes. The GLP-1 analogs are subcutaneous drugs. Exenatide has a twice-daily form, but it also has an extended-release form that can be given once per week. Liraglutide is administered once daily, and dulaglutide is administered once per week. GLP-1 analogs are usually not used as initial therapy. They're usually add-on therapy in patients on multi-drug regimens, for example, a patient with metformin who has not achieved their A1C target. Good things about these drugs is they do not usually cause hypoglycemia and they are associated with weight loss. Another thing to know about these drugs is there have been studies of the GLP-1 analogs in patients who have diabetes and cardiovascular disease, and these drugs have been shown to reduce mortality. For example, there was a study of liraglutide in patients with diabetes who had a history of coronary disease or stroke, that's cardiovascular disease, and over a couple of years, death from cardiovascular disease was reduced among patients who took liraglutide. So when you're treating patients with diabetes and they need an add-on medication, if they have a history of stroke or coronary disease, these drugs can be good options because they may lower their mortality rate. The main side effects are GI-related side effects. These drugs can cause nausea and rarely vomiting and diarrhea. The next group of drugs are the DPP-4 inhibitors. These are the gliptin drugs like sitagliptin, linagliptin, and saxagliptin. All of these drugs inhibit DPP-4, which is dipeptidyl peptidase 4. This is an enzyme that's expressed on many cells, but one of its roles is that it inhibits the release of GLP-1 from intestinal cells. So if you inhibit the inhibitor of GLP-1 release, what you get is a boost in GLP-1 levels. And so that's how these drugs work. They raise the level of GLP and produce GLP-like effects, including stimulation of insulin release. The DPP-4 inhibitors are oral drugs, and in terms of side effects, in the clinical trials of these drugs in patients with diabetes, one of the main side effects has been the development of infections. There is some evidence that these drugs may depress immune function. So patients taking DPP-4 inhibitors in trials have had an increased rate of developing nasopharyngitis and other respiratory tract infections. And then other things to know are that these drugs are weight neutral, so they don't cause weight gain or weight loss, and they haven't been associated with hypoglycemia. Okay, our last group of anti-diabetic agents are the SGLT2 inhibitors. Drugs in this group include canagliflozin and dapagliflozin. So SGLT2 is a renal glucose transporter. It's expressed in the proximal tubule and it reabsorbs sodium and glucose. And it's responsible for reabsorbing about 90% of the filtered glucose at the nephron. So if you inhibit this transporter, glucose will go out in the urine and that will lower glucose levels. And because there is more glucose in the urine, this will cause a mild osmotic diuresis, and therefore these drugs are also mild diuretics. SGLT2 inhibitors are oral medications, and one of their benefits is they lead to mild weight loss. You're basically spilling glucose in the urine when you take these drugs, and that's like burning a bunch of glucose every day and burning some calories every day simply by taking this medication. The adverse effects are related to the fact that there's more glucose in the urine and that increases the likelihood of infection. So there's an increased risk of vulvovaginal candidiasis in women. There's also an increased risk of urinary tract infections. Because these drugs are mild diuretics, they can lead to volume depletion, and they're not used in advanced renal disease. That's because those patients have a low GFR, and if you reduce the circulating volume with a diuretic, you can worsen the renal function. And then lastly, a super high yield thing to know for your boards about the SGLT2 inhibitors is that they've been shown in large clinical studies to improve outcomes in patients with systolic heart failure. In the cardiology section, I talk about how we treat systolic heart failure with drugs like beta blockers and ACE inhibitors. Well, there are new studies showing that if you add to the regimen for patients with systolic heart failure an SGLT2 inhibitor, you also improve outcomes. You make it less likely the heart failure will progress and less likely the patient will be hospitalized for heart failure. Okay, so now that we've gone through all the drugs, let me leave you with some helpful tips on when to use or not use certain types of diabetes therapy. So in patients with renal failure, remember that you want to avoid metformin, and that's because in this situation there's an increased risk of lactic acidosis. In patients with advanced heart failure, you want to avoid the glitazones because they cause fluid retention, and you also want to avoid metformin in this group because they also may develop lactic acidosis. You should know that insulin is generally safe with any comorbidity, so among complex patients who have advanced kidney disease and advanced heart disease, insulin is generally always a safe option to go to. And then there are many patients with diabetes who have cardiovascular disease like coronary disease or stroke, and you want to remember the two groups of drugs that have been shown to be beneficial in those patients. So the GLP-1 agonists, like I mentioned earlier, have been shown to reduce mortality in patients with diabetes and cardiovascular disease. And the SGLT2 inhibitors have been shown to improve outcomes in patients who have diabetes and systolic heart failure. And then this may not come up on your board exams, but one thing you should be aware of for your clinical rotations is that among hospitalized patients, oral anti-diabetic agents are often held or avoided. The reason for this is because blood glucose levels fluctuate a lot when patients are critically ill. They often don't eat, and that makes them prone to hypoglycemia, and they have high cortisol levels, and that can make the blood sugar become high. So because the blood glucose levels bounce around so much, oral anti-diabetic agents, which are designed to be administered once a day in many cases, are usually avoided. Instead, most patients are treated with insulin, often regular insulin, sometimes other forms as well. And the idea here is that this is a short-acting treatment for hyperglycemia, and you can modify it throughout the patient's hospital course. So for the most part, when you're treating inpatients who are critically ill, you're going to see insulin used and you won't see drugs like metformin and other oral anti-diabetic agents. You also should be aware for your board exams of the limits of what the oral anti-diabetic agents can do. So most of the oral agents decrease the hemoglobin A1C by anywhere from 0.5 to 1.5%. For example, metformin, which as we talked about is the most common initial drug, can decrease the A1C by 1 to 1.5%. So what this means is when patients have a markedly elevated hemoglobin A1C, they're usually going to need to be treated with insulin because only insulin can bring down the A1C by numbers like 3, 4, or 5%. So at the time of diagnosis, for example, if the hemoglobin A1C is greater than 9.5%, usually the patient is started with insulin because you just aren't going to be able to get 9.5% down to the target range of under 7 with oral anti-diabetic agents. And that concludes our module on diabetes treatment.